Hello, this is Horacio Dancia. I'm a hand surgeon at Virginia Tech Carilion in Roanoke, Virginia. I'm talking today about perilunate fractures and dislocations. It's important to start with the definition. Perilunate injuries are essentially dislocation or fractures and fractures of the carpal bones relative to the lunate, where lunate stays reduced by the carpal bones around it are dislocated or fractured relative to the lunate. In lunate dislocations, the lunate dislocates volar or dorsal, but the remaining carpal bones stay in the anatomical location. Those are rare injuries, result of high energy injuries, and there's no large data samples to get the true incidence. They are thought to be about 10% of all carpal injuries, with perilunate fracture dislocation representing about 5% of all wrist fractures. Unfortunately, about 25% of those injuries are missed on the initial presentation, resulting in significantly decreased worse outcomes after late presentation. Talking about anatomy, which is very important in the wrist. There's important osseous and ligamentous structures that can be both implicated in perilunate and lunate dislocations. Understanding the complex anatomy is paramount for restoration of anatomy and the subsequent function. We should talk about the intrinsic and extrinsic ligaments. The intrinsic and interosseous ligaments are entirely within the corpus, with the intrinsic ligaments possibly crossing from the proximal to distal row, and the interosseous ligaments essentially being between the carpal bones of the same row. Extrinsic ligaments are thought to be thickening and capsule between the radius and corpus, and they are named by the sites of attachments, radial to ulnar, inner radial to ulnar, and proximal to distal direction. We'll talk about those ligaments in a few minutes. Lunate anatomy is also important as a type 1 with not facet for the hamate versus type 2 with hamate facet have different stability, as type 2 lunate is more stable, as the second facet for the hamate does provide more stability. The lunate has a natural tendency to extend within the wrist. On the other side, the scaphoid appears to be look like a twisted peanut. The forces, including the trapezial forces on the distal scaphoid, tend to flex and rotate the scaphoid. Intrinsic ligamentous injury is important in deciding what to repair, as the scapholunate ligament is the strongest dorsal, while the lunotriquetral ligament is strongest palmar. Both those ligaments have a dorsal palmar and proximal membranous portion. The extrinsic ligaments could be dorsal or volar. The dorsal ligaments are radiocarpal, which are the radiolunate and radiotriquetral ligaments between the radius and above named bones, and also the dorsal intercarpal ligament that crosses the entire corpus dorsally between the basically between the trapezium and trapezoid on the radial side, and the triquetrum ulnarly. On the volar side, we have the radial-sided ligaments, which starting from the radial styloid are radioscaphocapitate, long and short radiolunate, which stabilize the radial side of the wrist. And then we have the stabilizers of the ulnar side of the wrist, which are ulnar capitate, ulnar lunate, and ulnar triquetral ligaments. It's important to know about the space of Poirier, which is a virtual space on the volar capsule of the wrist. It's an area void of ligamentous attachments between the capitate and lunate. Again, this is a volar space. It's frequent that we have a capsular rent within a space of Poirier with perilunate dislocation, and such space could be enlarged if we decide to use a volar approach and repair the lunotriquetral ligament. Regarding the motion of the corpus, it's important to know that all motion of the carpal is centered essentially around the head of the capitate. The proximal row has no tendinous attachment. That's why it is a free intercalated segment. And the radial deviation of the wrist is flexing the scaphoid, while ulnar deviation is extended. This is the base of the Watson test to test for scapholunate ligament injury. When we talk about imaging on plain radiograph, we should evaluate for the Gilula lines, which represent the proximal and distal curvature of the proximal carpal row and respectively proximal curvature of the distal carpal row. And a break in those lines is a sign of change in carpal alignment, which suggests perilunate or carpal injury. Also, different changes are capitate and lunate overlap. A piece of pi sign on the PA radiograph where the lunate appears like a triangular piece of pie, or a spilled teacup sign on the lateral view of the wrist where the lunate appears like a teacup that has been turned vertical and essentially spilled teacup, as you see in the image on the center. Scapholunate angle, it's an important parameter that we measure with a normal value between 30 and 60 degrees and average of 47 degrees. A value over 60 degrees suggests injury to the scapholunate ligament and carpal malalignment. Similarly, a lunocapitate angle, and normally it's up to 10 degrees, and any value over 15 degrees suggests carpal malalignment as well. Another parameter, it's the carpal height ratio. Essentially, it is the distance between the base of the third metacarpal to the distal radius divided by the length of the entire third metacarpal. And normal, this is 0.54 plus or minus 0.03, so slightly more than 0.5. Advanced imaging could be useful in certain patients. A CAT scan could be useful to detect underlying fractures, but should not be done before reduction. Every time a patient presents with such an injury, reduction should be attempted first, followed by advanced imaging. MRI could be useful in patients with perilunate injuries and isolated ligamentous disruption like scapholunate or lunotriquetral ligament. Arthroscopy similarly could be used for isolated ligamentous injuries or in chronic injuries where we need to assess the articular cartilage to decide on the appropriate treatment. It's important to define different types of carpal instability, which could be dissociative. That means is a malalignment within the same carpal row, for example, scaphoid fracture or scapholunate ligament tear with change in position between those bones, versus non-dissociative, where the malalignment is between different carpal rows, for example, mid-carpal malalignment between the proximal and distal carpal rows. Perilunate dislocation, it's actually a complex carpal instability, which has components of both dissociative and non-dissociative instability. Other types of carpal instability are adaptive, which is extrinsic. It's secondary to deformity outside the carpal, outside the corpus. For example, radius malunion could be such a cause. The etiology for such injuries is always a high-energy trauma, which could be fall on hyperextension and supination when we fall forward onto the thenar muscles on the thenar area with a wrist and ulnar deviation, versus a fall backward, also in hyperextension, but in pronation this time, when we fall on a hypothenar area with the wrist in a radial deviation. Mayfield's progressive perilunar instability diagram describes the injuries happening through such a fall. It is thought to be a part of a continuum that, depending on the severity of injury, we can have a more limited or a more complex injury. In first stage, the scapholunate ligament ruptures, resulting in scapholunate dissociation, followed in stage 2 by capital lunate dislocation, stage 3 lunotriquetral dislocation with lunotriquetral ligament rupture, and finally in stage 4 through lunate dislocation, which could be volar or dorsal. If the amount of energy within the injury is not sufficient, this can stop before reaching a stage 4, and there could be a more limited displacement within the wrist, within the corpus. It's important to define the greater and lesser arc injuries as well. The lesser arc injuries essentially are injuries of the ligaments surrounding the lunate, scapholunate and lunotriquetral ligaments, while the greater arc injuries involve fractures of the adjacent bony structures, fractures of the radial styloid, scaphoid, and capitate. And those could be grouped in transradial styloid injuries, transscaphoid, and or a combination like transscaphoid, transcapitate, or an injury through the 3 bones, transstyloid, scaphoid, and capitate. When seeing a patient with such injury in the emergency room, there's a history of acute trauma, as I mentioned, high energy. Wrist swelling could range anywhere from mild to severe. It's important to check the neurovascular exam, as 25% of the patients at least have median nerve symptoms. More common in Mayfield type 4, where we could have a volar dislocation of the lunate, with the lunate being present, compressing the median nerve being present in the carpal tunnel. This results in a contusion of the nerve that may take a few months to improve, and is important to follow the nerve recovery through continuous to repeated evaluation. Management of such injuries after patient presents to the emergency room, we should attempt closed reduction when possible, as this may reduce the median nerve irritation, is reducing the swelling. The technique of Tavernier, it's the most commonly used. We should apply finger traps to allow traction on the wrist. Elbow is flexed at 90 degrees, and we apply anywhere in between 5 to 10 pounds of traction on the elbow. Patient should be given relaxation and sedation. And the wrist is now, in order to achieve reduction, the wrist is first extended. Then traction is applied on the fingers to allow the capitate to return, basically to create a space between capitate and lunate. Then the wrist is flexed while applying counter pressure palmarly onto the lunate, and this allows reduction of the capitate onto the lunate. After reduction, if this is successful, the patient should be placed in a sugar tongue splint. But if reduction is not successful, or if there's too much swelling, and if there are persistent median nerve injuries after reduction, patients should be taken to the operating room emergently for exploration and more definitive treatment. Timing of surgical treatment is slightly controversial. It is now accepted that in patients that have been reduced and have no median nerve symptoms, they can be fixed within a few days or up to a week. There's no evidence of any role for a closed management of such injuries as definitive treatment. The treatment is always open surgical. In patients with neurological symptoms or non-reducible injuries, emergent surgical management is necessary, as mentioned earlier. The approach is also slightly controversial at this point, as most accepted approach is dorsal, and many surgeons, many others suggest adding a volar approach, and I do think myself in my practice that volar approach has some benefit in some patients. The goal of the treatment is always fixation of any fracture, ligament repair, fixation of all dislocations, and median nerve decompression if necessary. That should be done for all acute injuries, and we define an acute injury one that has been seen within 8 weeks from the injury at this point. For late presentations, the repair is not always possible, and salvage procedures could be necessary, like proximal row carpectomy or total wrist arthrodesis in patients that already have degenerative changes for extremely late presentations. Dorsal approach, it's a longitudinal incision, just ulnar to Lister tubercle, after retracting the finger extensors and the thumb extensor and exposing the dorsal capsule. Ligament spotting incision should be made to preserve the ligamentous attachments. This is exposing the dorsal carpus and allows all the needed repairs. If we need to add the volar approach, this would be an extensile carpal tunnel approach that extends into the distal forearm after releasing the median nerve and retracting the median nerve and the flexor tendons to the fingers. This approach would expose the rent through the space of Poirier, which could be extended to allow access to the volar ligaments and the volar aspect of the carpus. The pros and cons of double approach, volar and dorsal, are as pros. It's easy reduction through double approach. The double added exposure gives us better access to the distal scaphoid through the volar approach, ability to repair the volar ligaments, and also ability to do a carpal tunnel release. Now, the cons are, it is not extremely clear if repair of volar ligaments is actually necessary, and if it adds to the final outcome. The two incision will increase swelling after surgery, would increase the potential for carpal devascularization, and also due to scarring and resulting after maneuvering and releasing the finger flexors. There's going to be increased scarring around those tendons with difficulty regaining digital flexion and grip. More accepted at this point is a stepwise approach, starting with a release of the carpal tunnel if patient has carpal tunnel symptoms, followed by a dorsal approach through a ligament spotting capsulotomy. Once the carpus is exposed, the radiolunate joint should be stabilized, the lunate should be reduced, and a radiolunate wire, like a C wire or K wire, could be placed. In my practice, I place a 0.062 inch K wire through the dorsal lip into the lunate, and I cut it short right above the skin. That allows me to easily remove it at the end. And this creates a post. The lunate is reduced and stable, and we can reduce and repair the other carpal bones. We can reduce the other carpal bones and repair the other ligaments to the reduced lunate. Once the carpus is reduced, we should use a temporary fixation in a diamond configuration. First, I place scapholunate wires like a C wire or K wire, and those could be bypassed in patients with a scaphoid fracture, where at this point scaphoid repair should be done, and the scaphoid screw takes the role of those wires, followed by scaphocapitate K-wire, then triquetrohamate and triquetrolunate wires. This should be followed by repair of the intercarpal ligaments with anchor fixation or bone fixation, depending on the preference of the surgeon, and finally repair of the extrinsic ligaments where possible. If the intrinsic ligaments like scapholunate ligament is not repairable, then we can use different forms of capsulodesis to augment the repair. versus suture or tendon augmentation through different commercially available devices. Intercarpal headless screw between scaphoid and lunate has been used with some success, although there's high number of complications according to the current literature. Post-operatively, patients should be placed in a volar resting splint with the fingers free and should be referred to therapy immediately for finger range of motion, as finger stiffness is very common and starts early, followed by further immobilization in a short-arm cast or a Münster cast for another 6 weeks when patient is placed in a removable brace until pin removal. Pin removal should be around 10 to 12 weeks. Followed by continuation of therapy with addition of wrist motion and strengthening for the wrist and fingers. Complications, wrist stiffness, it's a very common complication. It's almost expected that the patient will not have the pre-injury range of motion. CRPS, it's more common due to severity of injury, and it's even more common with patients that have median nerve injury. Arthritis due to cartilage damage and finger stiffness. The goal of any treatment, and similar for our treatment in this condition, is a functional, stable, and non-painful wrist. And we accept some stiffness as long as the wrist and hand can be used essentially for full activity and does not generate significant pain. A condition that is worth mentioning is a transient lunate ischemia, where within a few months after the injury and the repair through surgery, the lunate appears radiodense on the X-rays. This appears up to 12.5% of the cases, and in general, it's self-limited and resolves spontaneously within a few months. This is all I have for today. Thank you for listening to my presentation.